Statistics.
So time finish. We can start. I will just set the time and let you just 1 minute.
Okay.
Okay, start.
So in the video, I can see a 10-year-old boy lying on the bed with the oxygen attached and with IV cannula and BP cuff in the right lower legs. He shows jerky movement of his right upper limb with some slight movement of his legs and some movements in the face as well. So, yeah.
Okay. So what history you want to take in this patient?
I'd like to ask about the onset and the duration of these activities, and it's going on for how long, and the history of previous episodes, and his developmental milestones, and his family history of seizures.
Okay. Anything else you want to take in the history?
I also like to ask about is he under any anti-epileptic before, and his any history of trauma, or and yeah, these things. Yeah.
Okay. So examination, what do you want to take?
Yeah. At this moment, I would like to check the blood glucose level. But before that, I would like to see his first stabilize himself, by AVC maneuver. Like I can see he is already on oxygen. So I will make sure his vitals are okay. Put on the left lateral positions, and then I will grossly check his. Before that, I will check his blood sugar level, and I'll proceed to stabilize him by the antibiotic drugs.
Okay. So what is your differential diagnosis in this case?
It looks like a seizures. After asking about the durations, I can say it's a status epilepticus or not, and it can be of even partial seizure with status epilepticus.
Okay. You mean partial with secondary generalized?
Yeah, generalized and in status epilepticus.
Okay. So how do you want to investigate and manage this case?
First of all, I will check the blood glucose, and then in the meantime, I will secure for IV access, and I will give this IV lorazepam 0.1 mg per kg, and I will see observe for around like 5 to 10 minutes. If not controlled, then I will give second dose of IV lorazepam, and then if not controlled with this second dose of lorazepam, then in next 5 to 10 minutes I will load with the. I will ask him whether he is on phenytoin or not. If he is not on phenytoin, I will load phenytoin 20 mg per kg. And if not, if he is already on phenytoin, I'll go for levetiracetam or phenobarbital. And meanwhile, I will inform my consultant, senior consultant, if for this.
Okay, if the seizure continues, what will be your next step?
If seizure continues with the phenytoin, then I will consider transferring to the PICU. Before that, I will inform the my consultant, as well as the anesthetist, and I will go for rapid sequent intubations and with this anesthesia and put on the muscle relaxant.
Okay, so can you tell what about detailed investigations? What do you want to collect the blood for in this child?
Okay, from the blood, I will look for this. First of all, blood glucose, including this electrolytes, sodium hyponatremias, and also the calciums, magnesiums. The other things I'll check for the blood septic screening with the blood count, complete blood count, CRP, ESR, and I will also send blood cultures and blood and meningococcal PCR, blood PCR. And if it is a first case with the GTCS, then I will consult with this consultant for the CT, urgent CT, after taking the opinion.
Okay.
And after stabilizing the child, if it is a septic, it looks like a meningitis. After the child is vitally stable, and if the platelet counts are normal and this is normal, I will go for lumbar puncture with the to look for the CSF picture.
Okay. So just 12 seconds left. If it is, can you tell about pre-hospital management? If it happens in pre-hospital, what they are doing usually?
First of all, the child should be taken to the safe, put on the safe place, away from these dangers like fire and all these things, and should be kept on the left lateral position. Should not be given any fluids or anything by mouth. And if the seizure is more than 5 minutes, has to be brought to the hospital by calling the emergency.
Okay, anything they can give in the
yeah, if they have the buccal midazolam, if it is a the buccal midazolam is available, they can give a buccal midazolam.
Okay. Okay, time finish. So enough.
Okay.
I think your description was good. You told that this is a 10 years old boy in the hospital setting on oxygen, and there is jerky movements of the hands and limbs. Yes, the in the video, the right upper limb was more jerky, but all the other limbs were also jerky, but more was right upper limb. And he was on oxygen and BP cuff was told, but I don't know where exactly you see the IV cannulation here. Is it covered somewhere? And there are some patches here. I don't know for what this one. Maybe you will see IV cannula, but here I did not see. Okay, definitely he will be on IV cannulation. Then history. In the history, I think the most important you missed was the fever. I asked you,
Okay, yeah.
you did not tell fever, and also any drug ingestion.
Yeah.
Drugs history. You told about anti-epileptic medications he is using. It may be the past history if he is known case of epilepsy or something. But any like drug ingestion causing the seizures, you missed these two things: fever and drugs. You did not tell. Otherwise, you also asked about the past history, family history was asked. Even you can touch about for the tumors history, you can also touch about any vomiting, headache, any weakness in the body before like this. Okay, this you did not ask. And in the examination, for the examination, you went like management. I don't know. In the exam, we have to tell. Maybe in this child, you will prefer to do complete neurological examination. But presently, you will tell you have to stabilize the child. Okay. Complete neurological examination and for the associated causes for the seizures. Like if there is fever, you will look for the focus. Maybe it is CNS, but still you will look for other focus of the fever. And also, I don't know whether from, if we ask for examination, we can go for management. I don't know here at this point of time. Definitely the last questions will be
Doctor,
investigations and
can I say like after managing the seizures, I would like to examine this thing.
this is
That
better.
is the,
Yeah, after doing
yeah.
emergency management of the patient or after controlling his seizures, I would like to do the complete neurological examination. And also if he has fever, I would like to check any other focus of infection like this. This can be, but less likely in a 10 years old child. Suppose if the child is between 6 months to 6 years, it can be just if they present you as febrile seizure. I mean, it's just due to fever. You can look for other cause for infection. If it is not status epilepticus, simple febrile seizure, which lasted for just a few seconds like this. So just tell like this here in the examination part. Then your differentials were fine. You cannot say without knowing the time whether it is the status epilepticus or not. But you still said you will know the time, how long, and you will decide. And your investigations and management, you went directly to the management. Investigations, you just told me blood glucose, but during the investigations, add here everything. You want to do the septic workup, so CBC, CRP, blood culture. And if you are suspecting of meningitis, after stabilizing the child, you can go for LP. And then you told blood glucose, very important bedside examination. Then after stabilization also you will go bedside, you can do fundoscopy once the child is stabilized. And as you said, electrolytes is very important in these cases, and also VBG. I don't know whether you told blood gas or not. I am not sure. Okay, complete electrolytes and VBG. Then your this was correct. Your what you said, the management. First you will give the lorazepam 0.1 mg per kg. Then again second dose lorazepam 0.1 mg per kg. So when you will repeat the second dose after giving first dose? After how many minutes?
Maybe 5 to 10 minutes, right? At 5
minutes.
minutes, we'll giving the first dose, and around 15 minutes, we'll giving the second dose.
10 minutes. 10 minutes is the window. So 5 minutes you gave now lorazepam. You will again assess the child. You will keep on monitoring him and assessing him. You will give 10 minutes time. If not improved, you will give the second dose. Then after how many minutes you will decide for phenytoin?
Next 10 minutes.
Yes, next 10 minutes. Again, you will wait for 10 minutes. If not, as you said, if he is on phenytoin, you will choose phenobarbital. Otherwise, you will go for phenytoin. Then you will again wait for 20 minutes after giving the phenytoin. From the time of phenytoin, still not improved, you will also, you can also tell the team here that you will involve your consultant and also neurologist and the anesthetist if needed for anesthesia. Okay. And one more point, if pre-hospital any benzodiazepine is given like midazolam, or I don't know if is diazepam outdated nowadays, they are still using rectal diazepam. I am not sure about it. if you give pre-hospital midazolam, it will be considered as first dose already given. So in your hospital management, you will just give the second dose of lorazepam and continue with the other steps. Okay. So this is my comments. I don't know, even I would have missed anything. And also tell me about the recent about diazepam they are using or not, anyone.
In the guidelines, this one NHS guideline, they have written a book buccal midazolam or rectal diazepam, I suppose. If IV cannula is not, IV access is not success, also we can give buccal midazolam everyone at the hospitals.
Yeah, midazolam is written here in the guideline, but diazepam he hasn't written. I don't know why. So I am just asking.
It is recommended only for at home. Especially for buccal midazolam is not available. We can give diazepam suppository, but not for IV.
Yeah, that is what the pre-hospital only we are talking.
Yeah.
If buccal midazolam is the first choice. If
Yes.
it is not available, we can go for rectal diazepam. So I will share this. And I wanted to ask you one more question about the definition of status epilepticus. I forgot, I did not ask you.
It's if it is more than 5 minutes without gaining the conscious level, or means any fever, any seizure more than 5 minutes. Before it is 30 minutes. Now
Yes.
they change it to 5 minutes without gaining the conscious level.
Okay. So this is in the red book about status epilepticus. Follow each step until seizures resolve, but do not treat post-ictal posturing as seizure. Okay. So prepare next step in algorithm immediately after previous one administered. Do not give more than 2 doses of benzodiazepine, including any pre-hospital dose. So suppose if the pre-hospital it is given by the parents or by the ambulance crew or anything, you will not give. So here the very important is you will prepare the next step in the algorithm and be ready if needed to administer. So here the time is 0. This is the starting time for you. That is from the time of start of seizure. Then 5, 15, 25, 45 for your actions. So after giving the first dose, in 10 minutes, if there is no improvement, you will go for the second dose. Then in 10 minutes, if there is no improvement, then you will go for phenytoin or phenobarbital, depending upon whether the child is on phenytoin or not. Then after 20 minutes, if still there is no response, you will go for rapid sequence induction of anesthesia with thiopental. So, so know the time window. 0 is the starting point, then 5, 15, 25, 45. Okay, 45 minutes. So first what you will do immediately for the patient, check ABC, high flow oxygen, and check blood glucose. So in our child, we were seeing that he was on the high flow oxygen. Okay, and you will check the ABC and blood glucose, immediate action you have to do. So clinically confirm epileptic seizures. Next, at 5 minutes of time, okay, if IV access has been established, you will go for lorazepam 100 micrograms per kg. 100 micrograms is nothing but 0.1 mg per kg. So then here he has given in comments, midazolam may be given by parents, carers, or ambulance crew in the non-hospital setting. Next, then at 15 minutes, that is 10 minutes from the first dose, if there is no response, you will give second dose of lorazepam, again 0.1 mg per kg. And this will happen to take place in hospital setting. You, at this point, when you administer second dose, you will call for the senior help, start to prepare phenytoin, reconfirm it is an epileptic seizure. Again, you will confirm that still whether the child is in seizure or not. Then at 25 minutes, give phenytoin 20 mg per kg. It is irritant to wane, so you will give slowly over 20 minutes. Okay, 20 mg per kg over 20 minutes for phenytoin. But phenobarbital you can give fast, like 5 to 10 minutes. But for the phenytoin, remember you will give slowly because it is irritant to veins. If on regular phenytoin, if the patient is on regular phenytoin, the choice will be phenobarbital. Same 20 mg per kg IV. It will be given over 5 to 10 minutes. Okay. Then here, inform PICU staff or senior anesthetist. So you're in the next step, you are in need of anesthetist if he is not improved in 20 minutes. So you will keep the anesthetist ready. So he will be informed and he will also be available with you. So in the PICU, informing and transferring to PICU becomes important. So paraldehyde, here he has told about paraldehyde, 0.8 ml per kg of mixture, 50:50 diluted in olive oil, may be given as enema. But for this, don't tell it as a regular medication. For this, you will ask the senior advice. Maybe if there is no available IV line or something, because this is through enema. I'm not sure. Okay, how often they use and how commonly they use. So for us, the common things is the first dose of lorazepam, then after 10 minutes, second dose of lorazepam. Then after 10 minutes, if there's no improvement, you'll go for phenytoin. If the patient is on phenytoin, your choice will be phenobarbital. Then after 20 minutes, you will make the anesthetist ready, and also preferably you will transfer the patient to PICU, and for the rapid sequence, induction of anesthesia. Okay. So phenytoin, here he has told us, right, it's an irritant, IV irritant, so it has to be given slowly over 20 minutes. About this, he has given here how to give. Okay. I don't think they will ask us in the exam. We should only know that it should be given slowly. This you can read it later. For midazolam, the doses, the buccal midazolam is given here. Less than 3 months, 300 micrograms per kg. Then 3 to 11 months, 2.5 mg, 1 to 4 years, 5 mg, 5 to 9 years, 7.5, then more than 10 mg. So I don't think this will be asked. Anyone has any comments on this before we go for the definition?
Dr. Noor, I have a question. Like regarding investigations, the CT scan in EEG in acute case, like how, like, so it should be anywhere it mentioned in for in the status.
You can mention, because if this is a first presentation, surely, like if it is a known case of a CP or anything, they already know about the patient. I don't think no. As you mentioned, if it is a first time presentation, definitely you will go for all these investigations. Here it's mentioned, you see, treating prolonged or repeated seizures in community, give immediate emergency care and treatment to children and young people, adults who have prolonged lasting for 5 minutes or more. Repeated, that is 3 or more in an hour, but this repeated, you should tell something here. That repeated without gaining of consciousness means still the child did not come in the consciousness and it is continuing. This will be the definition. So prolonged more than 5 minutes, lasting for 5 minutes or more, and repeated 3 or more in an hour. Convulsive seizures in community. See here it's written, only prescribed buccal midazolam and rectal diazepam for use in community in children, young people and adults who have previous episode of prolonged or serial convulsive seizure. So even they are using buccal midazolam or rectal diazepam. Something one, I think maybe he has given down, we will read it later. Administer buccal diazepam as first line treatment in children, young people and adults with prolonged or repeated seizures in the community. Administer rectal diazepam if preferred or if buccal diazepam is not available. So the first option for you will be buccal midazolam. You will go for rectal diazepam only if it is not available, or if it is preferred, he is telling. Why, I don't know. If IV access is already established and resuscitation facilities are available, IV lorazepam. Treatment should be administered by trained clinical personnel or if specified by an individually agreed protocol drawn up with a specialist by family members or carers with appropriate training. Care must be taken to secure the child, young person or adult's airway and assess his or her respiratory and cardiac function. So depending on the response to treatment and person situation, any personalized care plan, call ambulance, particularly if seizure is continuing 5 minutes after emergency medication has been administered. Person has history of frequent episodes of serial seizures and have convulsive status epilepticus, or this is the first episode requiring emergency treatment. There are concerns or difficulties monitoring person's airway, breathing, circulation, or other vital signs. So even when you are outside, if there is buccal midazolam available, it will be the first choice. The second, if not, rectal diazepam, or in the they reach the hospital setting and there is IV cannula, you will go for IV lorazepam. So treating convulsive status epilepticus in hospital for children and young people and adults with ongoing GTC who are in hospital, first secure the airway, give high concentration oxygen. So high flow oxygen, you have to mention this in your management. Assess cardiac and respiratory function. So you can tell cardiorespiratory monitoring, airway circulation and breathing, then give high concentration of oxygen, cardiorespiratory monitoring, then blood glucose level and secure intravenous access in a large vein. Administer IV lorazepam as first line treatment in the hospital in children with ongoing GTC seizures, convulsive status epilepticus. Administer IV diazepam if intravenous lorazepam is unavailable, or buccal midazolam if unable to secure immediate intravenous access. So if lorazepam is not available, then even you can go for IV diazepam, okay, if not available. And if IV access is not there, you will go for buccal midazolam. Administer maximum of 2 doses of first line treatment, including pre-hospital treatment. If seizure continue, administer intravenous phenobarbital or phenytoin as second line treatment in hospital in children with ongoing GTC seizures, okay. Treating refractive convulsive status epilepticus, we saw already the fourth will be, you will involve the anesthetist and for the rapid sequence induction of anesthesia. So children and young people, administer intravenous midazolam or thiopental sodium to treat children and young people with refractive convulsive status epilepticus. Adequate monitoring, including blood levels of anti-epileptic drugs. If the child is on previous anti-epileptic drugs, this will also be your investigation. Blood levels of anti-epileptic drugs also. Okay, critical life system support is required. As treatment pathway progresses, the expertise of an anesthetist and intensivist should be sought. If either the whole protocol or intensive care is required, the tertiary service should be consulted. Regular AEDs should be continued at optimal doses, and reason for status epilepticus should be investigated. An individual treatment pathway should be formulated for children, young people, and adults who have recurrent convulsive status epilepticus. Okay. So there is something called non-convulsive status epilepticus also, which we should know. Next, for the definition here, this is the definition you should know. AED is anti-epileptic drugs, medication taken daily to prevent recurrence of epileptic seizures. Then convulsive status epilepticus. If they ask you what is the definition of convulsive status epilepticus, a convulsive seizure that continues for longer than 5 minutes, or convulsive seizures that occurs one after the another with no recovery in between. This is very important. You have to tell it in the same way. A convulsive seizure that continues for longer than 5 minutes, or convulsive seizure that occurs one after the other with no recovery in between. This is an emergency and requires immediate medical attention. So at least we should know this much for the definition. Okay. This they may ask if it's a then generalized tonic-clonic seizure, a seizure of sudden onset involving generalized stiffening and subsequent rhythmic jerking of the limbs, the result of rapid widespread engagement of bilateral cortical and subcortical networks in brain. Okay. So we all know that there will be stiffening and sudden rhythmic jerking movements of all the limbs. Okay. And this will be due to the bilateral cortical and subcortical networks in brain. There will be discharges. That's why. So non-convulsive status epilepticus, a change in mental status or behavior from baseline associated with continuous seizure activity on EEG, which is also seen to be changed from baseline. That means the child, you don't see here in non-convulsive status epilepticus, you don't see the child stiffening or jerking movements, but the EEG will be recording the recording in the EEG you can see. So this is what he is telling. Okay, the electrical impulses will be recorded on the EEG, but you don't see the child in the state of convulsion. Okay, so for children and young people, a pediatrician with training and expertise in epilepsy, okay, that is not needed. So anyone wants to add anything about non-convulsive status epilepticus?
Doctor,
Yeah,
can I come in?
yeah, please.
I just want to ask one question, because that term, convulsive status epilepticus is sure. Like I think I understand, but real other than jerky movement, because it could be factitious also, no? So how to differentiate between the factitious epilepsy without EEG availability on your clinical exam?
What did you, what is your, I couldn't get your question. Can you repeat it again, please?
Doctor, I just want to ask, in convulsive status epilepticus, which they mentioned, then yani this jerky movement of the limb that persists for 5 minutes,
Long
or
and 5 minutes, yeah.
yeah. So this jerky movement can be because of some factitious disorder, like it is not true disorder, pseudo epilepsy, you can say.
Oh, epilepsy, usually you will get to know. I have seen usually the pseudo epilepsy will be presented in the age of teenage. Okay. Teenagers, and if you take the history, there will be something like social history, fighting or some problems like this. You can easily differentiate. I mean, it will not be like they will be conscious at one moment of time when you're not seeing, they will be okay, and suddenly when you go there, they start moving their hands. I have come across this. You can make out as a clinician whether it is pseudo or real. Okay, and usually it will be presented by teenagers, and if you take the history, there will be something in the home, like they fought before this or some stress like this.
Oh, I understand. And one more thing I would like to ask, like in true epilepsy, what could be the changes or abnormality we can encounter in the vitals, specific abnormalities in the vitals in the true epilepsy?
I don't know actually, but
Yeah, in
Maybe
vitals, I think in
the
vitals,
autonomic activities like tachycardia, bradycardia, the saturation, drop on saturation, anything can happen, right?
wait 1 minute, Dr. Satish. Okay, please open your mic.
Yeah, during seizures, the child can have autonomic dysfunctions with the tachycardia, bradycardia, drop in saturations. Is right?
yeah, I think during seizure there will be tachycardia and hypoxia and tachycardia.
Hypoxia is very important complication here, which can cause problems and mean long-term sequels. That's why they immediately start on oxygen.
Dr. Noor, I have one question regarding the treatment for non-convulsive status epilepticus. Is it the same like the convulsive status epilepticus?
There is an article here. We have to go through it because see here, he has written a suggested protocol can be found in Appendix F of the guideline. But as far as I know, they are usually refractory to regular treatment. They need some special involvement of neurologist and some special treatments like I am not sure, like steroids or immunoglobulins, something like this. But you have to go through this Appendix F. I don't know if we can open it.
Okay. One of the doctors asked what about what abnormality in the vitals for convulsion. I think there is a clue that any convulsion causing hypoxia and tachycardia, and by also we can differentiate from apnea. They have the same presentation because as convulsion, that apnea associated with hypoxia and bradycardia, but convulsion there is hypoxia and tachycardia.
Okay. So for the differential in this case, how we will give this is a clear case of you're seeing GTCS. So you will tell if this seizure is lasting for more than 5 minutes, it will be taken as status epilepticus. Okay. This you will tell to them, but how you will give the differential? You can say that it may be due to infection, trauma, tumor, or previous insults to the brain, like hypoxic ischemic injury, all these things, right? Like this, you have to give the differentials for the presentation of generalized tonic-clonic seizures, right, Dr. Satish?
Yeah, I also felt same because there is no any second clue for the GTCS. We have to give the differential diagnosis for the GTCS.
So here you will say that this may be due to
infections, trauma, or
encephalitis, trauma, tumors, drugs. Don't forget drugs. And also you can say the previous insults to the brain, like hypoxic ischemic injury when the child was small or preterm.
Pre-existing neurological conditions.
Okay, like you
CP,
can give some examples.
CP cerebral pulses.
Or
Yes.
Dr. Fatma, can we, like we can also say it could be acute infection like encephalitis. It could be trauma, tumor, or some metabolic abnormality can be one of the differential, because as we are taking some metabolic workup as well, like if if it's or status this epilepsy is not responsive to the treatment, can we add the metabolic abnormalities as well?
Yeah, you can add, but put it in the down. And also for this child,
No.
if you see, no, and also prioritize your differentials according to what you see in the video. This child, by his, mashallah, I don't see any wasting in his limbs. Okay, looking normal. This may be an acute presentation due to infection. This you can put it top, rather than putting this CP and previous neuro. Definitely the CP child, you will see some deformities or some wasting in the limbs like this, right?
Yes.
So here top you can put it as infection, even trauma, or any tumor also. Next, the top will be infection for me. Then you can say other causes like previous brain insults during the birth, maybe hypoxic ischemic injury or preterm birth, like this. Okay, and also you can put metabolic, but if it is metabolic also, in the picture for the 10 years, he's a well-grown child for 10 years, if I say him as 10 years, right? And no muscle wasting, nothing was there. So maybe this is an acute cause for his seizure than the chronic cause. So any chronic causes, put it in the down. This is what, prioritize your differential depending upon what you see in the video. Okay.
Okay, doctor.
So any comments before we go to the next case? Dr. Satish, you have shared one thing. This is from which book? Illustrated.
This is illustrated, yeah, illustrated textbook. This is
Yeah.
almost like same with that we have already discussed. Nothing new.
Yeah, same, but he has given like an algorithm, right?
Yeah.
And the other also you shared. This is also, I think, the same, right?
Yeah, leaflets. That's NHS leaflet, the same. Nothing new.
Okay. But when we read from this nice guidelines in the refractory seizures, along with thiopentol, he wrote midazolam. I don't know why. We will give also midazolam there.
We can give midazolam infusion, I think. If we are giving midazolam should be given an infusion.
Okay, so it is there in this leaflet. In the leaflet you have sent, it is written. Aim to terminate seizures with 30 minutes with midazolam infusion. Okay, but actually, to be frank, we will have only 3 minutes discussion. If we are able to produce this 0, 5, 15, 25, and 45 minutes action, I think it's more than enough, right?
Yeah, doctor. Yeah, I think it's we won't have much time.